I'd just like to welcome you. My name is Sarah Reid. I work at the Hampshire and Isle of Wight Healthcare. I'm working the communications team, and we have a series of member events which are open to members and staff throughout the year. And today I'm delighted to say that we are doing one on falls prevention. We did one back on falls prevention back late last year, and it was very popular. So I'm pleased. We've got some different people here today to talk to you about falls prevention. But just before we start, can we make sure that while the people are presenting, if possible, if you could have your microphones on mute so that there's least distraction for the people presenting. And I believe they will probably welcome questions perhaps at the end, but if you can't wait, put something in the chat so we can capture those questions as well. But I'll let Adi and Lisa, sort of talk you through that. At the end of this session, we will send an email out with a feedback form that we would be very grateful for you to complete, and also give you details of our next session, which is in May, and it's all about it's with Solent Mind, who are doing a session on 5 steps to staying mentally well. So if you want to join that one as well, I'll put a link in the chat right at the end. And also that will be on the feedback email. So if we could just mute everyone that's not speaking, that would be great. If I see someone, I will kindly go and manually mute you if you don't mind. But at the end of the session, we will have an opportunity to put your hands up and ask some questions, or put something in the chat. So unless there are any other questions about that, we're here till 1 p.m. Without further ado, I'll introduce Adi Phillips. Adi.
Hello, I'm Adi Phillips. I'm one of the falls leads for the Trust. I work in the Hampshire area of the Trust, and I tend to sort of visit patients on the ward, support with the inpatient and the community training that we deliver to the staff, as well as actually seeing patients not in our own time, but in work time that have been referred to us from the community care teams, or going to visit the wards. Now, looking through the chat to see where people have come from today, I can see that we've got a few people that have come from care homes with regards to sort of having a little bit of training or an update. What we're going to be doing with our team is we're going to be having a monthly session for care homes, which is going to be starting on Friday the 10th of April at 10 o'clock, and it will be a topic of the month. So one of the topics that I've been asked to speak to in care homes is footwear and slipper socks. So anyone that's from the care home, what I'll make sure is that I've given Sarah the link for that session, so that you can then come and join me and have that session talk and then a question and answer session. Staff training, if you're a member of the staff, we've got staff training online through the Development Lead Hub. So the next inpatient training I know is on the 15th of April, and another session is on the 4th of June, and that'll look at the policy and procedures and post-falls checklists and what we're asking people to do in case somebody has a fall. So the talk today is having a focus and thinking about those general risks about why people fall, but having a slant on as to why falls may increase in the springtime. And Lisa, who's one of the student nurses who's currently with us in the team, has actually done the presentation today, using it as part of one of her objectives, so that she's got a little bit about falls herself, but also that presentation experience. So having gone through with Lisa her questions and her slides, what we've decided that would probably be nicer for her is if any questions are put in the chat, I can then monitor that chat and we can do a collective summary at the end to answer those questions. And I'm also available at the end of the session at 1 o'clock if anybody wants to have a chat with me after that. So Lisa, if I just welcome you, she's switched off her screen. Does that mean to say that you've run away?
No, I'm still here. So what I'm going to be doing is I'm going to be sharing my screen with everyone at the moment. So yeah, I'll do that now.
Lovely. Over to you.
Right. So can everyone see the slide?
Yes.
Yeah. So obviously, as AD just said, we're going to be talking about falls prevention, but within the spring. So I'm just going to explain a little bit more about that now. So our main focus today is mobility and activity changes, environmental and ward factors, vision and auditory functions, hydration and nutrition, orthostatic hypotension, also known as postural drop, diabetes, bone health, medication and associated risks, and promoting a proactive, not reactive approach. So we've got a shocking statistic here. So it's from the Centre of Aging Better. So obviously 1/3 of people over the age of 65 and half of the people over the age of 80 fall at least once a year. This obviously leads to around 70,000 factors, and obviously leads to admission to hospitals and even mortality, and obviously admissions to care homes and stuff like that. So it's just looking at how we can prevent that sort of throughout the spring season. So obviously the Open University suggests that improved weather conditions are a significant influential factor in altering mood, motivation and increasing physical mobility. There's positive and negative factors of climate change. Obviously, positives include increasing strength and weakness, but unpredictable weather can lead to uneven surfaces and slippery mud. So obviously it's important doing that risk assessment at all times to make sure that there's no uneven ground and sort of risk factors that can lead to slips, trips and falls. With obviously footwear, within the winter, it's good that people use sort of more supportive shoes like boots and trainers and things like that. However, with the seasonal weather changes, people like to wear things like sort of sandals and Crocs and all that kind of stuff, and it's not good with stability and things like that. So it's important that people encourage patients to obviously use the right footwear, and assessing that mobility as well. Referrals to therapies, and as well it can lead to a muscle deconditioning with obviously winter pressures and stuff like that. So it's important that if people are affected by that, then they're again referring to therapies team and GP and everything, and encouraging that physical mobility. So obviously environmental and ward factors. So with the seasonal change, people like to do their spring cleaning and get rid of clutter and everything like that. So we want to encourage that safe cleaning. So obviously removing things like wobbly chairs and unstable ladders and things like that, because people like to overreach and sort of do unpredictable things that can lead to falls and everything. Things we need to look at, obviously within wards and stuff like that, is cluttered walkways obstructed by equipment, poor lighting, which can reduce the patient and staff's mobility, slippery and unmaintained surfaces such as loose rugs and thresholds, equipment positioned clumsily, obviously thinking about things like unlocked beds and wheelchairs, lack of support from grab rails such as on armrests and chairs, and even the position of the beds and chairs. Lack of signage in high traffic areas like toilets. So for instance, if somebody's in urgency of needing the toilet, we need to think about where these signs are positioned, and if people can see them effectively. And noise distractions as well, which can lead to patients rushing or becoming confused, sort of like misinterpreting instructions and things like that. So yeah, it's a kind of a bit of common sense really of sort of moving things out the way, and yeah. So vision and auditory function. So obviously I've put a list there of things that can cause visual and auditory sort of function impairment. But what we need to think about as well with the spring weather is spring allergies, sort of things like pollen increase and things like that. It causes obviously itchy eyes, irritation, sneezing, and people often take sedatives and antihistamines, which again cause people to feel drowsy and sort of dizzy and things like that. So it's keeping that sort of in mind when we're thinking about vision and auditory sort of things. Obviously, what we do recommend is regular eye checks, especially for patients that are over the age of 60. We like to do this sort of like once a year. Also, checking hearing aids, glare from windows, adjusting lights, checking bifocals, ensuring that they're all in good working order. Again, the signage, making sure it's clear. Establishing good communication needs and documenting this within the patient care plans as well, so everybody's all on board with the same thing. So hydration and nutrition as well, because of obviously increased physical mobility due to the weather changes, we need to obviously think about encouraging sort of more fluid input. So it's about taking that bottle of water outside, or even sort of smaller sips little and often. Obviously, evidence suggests from the Eat Well plate that these patients need between 1.5 to 2 litres per day. And obviously, this decreases the risk of urgency to rush to the toilet, and it prevents the risk of skin being dry, increases temperature regulation, and obviously it helps that patient to stay cool and prevent fatigue. And then we come on to orthostatic hypotension, which obviously people commonly know as postural drop. So obviously it's an autonomic dysfunction characterized by a drop of at least 20 millimeters of mercury in systolic and 20 millimeters of mercury in diastolic blood pressure upon standing, from sitting or lying. Causes of orthostatic hypotension include dehydration, medical conditions like heart failure, uncontrolled diabetes, or a hormone imbalance. Understanding orthostatic hypotension is important for its link for syncope, which is also known as fainting. So it impairs postural stability, and it can cause the patient to misinterpret footing and prolong recovery. So what we need to think about really is obviously again that 1.5 to 2 litres of fluid per day, and obviously reducing caffeine intake. And some GPs may do blood tests or review medication to manage symptoms of hypertension. Other things we can think about as well is checking thyroid levels, and obviously taking time from sitting to standing when getting up and not rushing, because again it's that sort of time limit of standing up and thinking, oh, I feel a bit dizzy here, I need to reach for my call bell, but it's just not sort of within reach and everything. So it's all those kind of factors we need to think about. Diabetes. So obviously it's the sort of standard sort of stuff with diabetes is hypos and hypers. So it's obviously managing that fluid level, checking for obviously sort of any neuropathy, stuff like that, sort of diabetic foot ulcers, and most importantly, a lot of people don't really know this, but it's about keeping that glucometer sort of out the sun, and within standard room temperature, because it can actually sort of influence the reading on the machines. So obviously these patients may feel a bit funny and go to check their blood glucose, sorry, and it may give the wrong reading. So it's those kind of things as well as keeping insulin in the fridge, and then obviously referring to the diabetic nurse for any concerns or anything with insulin and medication and stuff like that. So again, with Parkinson's disease, so individuals with Parkinson's disease are very sensitive to cold and heat regulations, and they have trouble sort of regulating their temperature. They also have trouble with multitasking as well, and their gait and stability. So again, when we think about the weather and stuff like that, and its unpredictability, and if you think about someone with Parkinson's, they have trouble sort of managing their stability. So if you have a sudden gust of wind or something like that, they're really going to fall. So it's important that obviously we are checking at all times for equipment, sort of that risk assessment, referring to therapies again, managing their blood pressure with fluid. And also, if they're having a bad day, you don't want to get them up, do you? You want to try and keep them in bed and sort of be as stable as possible. So yeah, it's just about that constant risk assessment, and any sort of concerns or anything you need to sort of let the GP know. So obviously we can make some modifications and things like that. And even the medications that they're on, some of them like levodopa cause dizziness, constipation and confusion. So it's all sort of factors that can lead to falls within people with Parkinson's. And then bone health as well. So as you can see on the slide, sunlight does improve the absorption of vitamin D, but it doesn't eliminate the risk of fractures and stuff like that. So again, it's that constant risk assessment and stuff, making sure a patient's got enough calcium within their diet. And there is a website as well. It's called the International Osteoporosis Foundation, and it's got a calcium calculator on there. So basically, if you feel like you're not getting enough sort of calcium in your diet, you can put the recommendations in there, and it will tell you what you need. So it's just a case of just keeping on top of that as well. Also, risks that are associated with this are sort of previous fractures within sort of like hips and wrists. They're the most common ones. Sort of diagnosis of osteoporosis and osteopenia. So yeah, it's just that those sort of regular checks all the time, escalating to the GP if you've got concerns, and obviously if you do feel like that there's something wrong, then you can ask for x-rays and stuff like that, any concerns with like sort of fractures or anything like that. And then diet as well, so obviously thinking about sort of multivitamin intake, sort of leafy green vegetables, all that kind of thing. And then again, medicine associated risk. So again, people that are sort of taking multiple medications, also known as polypharmacy, they're at high risk of sort of falling. Again, stuff like sedatives, antihypertensive, diuretics. Again, with the antihistamines, they can act as a sedative. So it's that risk again of sort of being sort of drowsy and falling over. And then it's just about doing sort of regular lying and standing blood pressures. If you do feel like somebody's got a postural drop, then you need to sort of refer to the GP again. And then after sort of taking the medications, it's again that risk assessment of sort of, is this patient giving me any soft signs? Are they showing me any symptoms of like dizziness, adverse reactions to medications, confusions, drowsiness, anything like that? And then obviously the worst, probably anaphylaxis, but then obviously you'd follow your protocol for that. And then it's obviously about promoting a proactive, not reactive approach. So basically prevention more than anything. So obviously assessing instability, furniture grabbing or surfing, changes in cognition, and then obviously incorporating into the care plans and everything with falls prevention. So yeah, it's just taking that risk assessment all the time, assessing the urgency when going to the toilet. So if people are rushing all of a sudden, again, that's an increase of falls. And then promoting their fluid intake and a nutritional intake, and yeah, it's about sort of that risk assessment really, and supervising the high risk patients, like obviously the patients with dementia, Parkinson's, that kind of thing, and obviously, yeah, linking back to the sedatives and everything. Risk assessment really. And if you feel like they're at risk, then it's about escalating, improving their fluid intake, assessing line and standing blood pressures, and even ensuring that the call bell is within reach, because I've seen it a couple of times. So I've gone into a patient and sort of tables halfway across the room, fluids halfway across the room, and call bells halfway across the room. And then again, it's just thinking, well, how's that patient going to call for help if they really need it? So yeah, it's just about sort of fluid intake, assessing bowels, mobility, medication, everything really. It's like completely holistic, but trying to incorporate that sort of within your care plans to make it sort of as easy as possible. So yeah, that's the end of it. So yeah, welcome in any questions. I've hopefully got AD with me helping me answer some of these.
I'm still here. You whistled through that, so we'll go for many questions, and then what we'll do. So I'll just, maybe if there's a topic or anything, but very well done, because it's quite nerve-wracking presenting to a large number of people, and the challenge of being online as well.
Thank you very much, Lisa. That was very good. Has anyone got any questions initially for Lisa? I think there was something in the chat, wasn't there, AD, around a checklist? No, Zara said no. Okay. Is there a checklist for the risk assessment items you are identifying? That was from Helen Lake.
So we have, so depending where you are, on the older person's mental, on inpatients, we have a falls assessment to be completed, and in the community we also have a few falls assessment, regardless of whether or not you're on System 1 or HIOW. Both of those assessments cover what's in the NICE guidance and the recommendations and what we need to be looking for falls risks. If you're in a care home, we do have our own version of a falls assessment, which is available for us to share with the care homes, so that you can have that version of the falls assessment as well. And again, that covers what's recommended in the NICE guidance. But we very much start off by looking at a falls history. And when I talk about a falls history, I very often use the word SPLAT. And I think about the S being, did the person have any symptoms? And were there any signs that they were about to fall? Was there anything that made them think, oh, I'm feeling dizzy, lightheaded beforehand, which might make them then fall? I then think about the P, which is the previous falls that they've had, whether or not they've had a lot of falls in one go, sort of like in the last 24 to 48 hours, which might suggest to me that there's a period of somebody being quite poorly, or whether or not it's a case that they've had in the past year just one or two falls and they've been explained. And this term very often we hear as being a mechanical fall, to say that actually they tripped over something and they fell, and it could be something that anybody could trip over. But for a lot of people, if you're younger, you've got the righting mechanisms to be able to prevent yourself falling, or you've got good eyesight and you can scan the distance, or you haven't got a problem with balance, so actually you don't trip over these things. The L in the SPLAT is for the location, and that would be the location of the fall. Was it by the bed? Was it the fact that they were lying alongside the bed where they'd rolled out of the bed? Or was it actually the fact that they'd got up from the bed and had fallen forward? And if they're rolling out of the bed, I might then be thinking about putting in place a low-level bed. Whereas if they're getting up and falling forward, I might be thinking about something as a bed lever to put in place. In ward environments, 70% of the falls very often are on the way to the toilet or coming back from the toilet. So I have a real thing about signage and making sure that actually if you're on a ward base, and being able from the patient's bed, is it clear where the toilet is and would they easily be able to find it? The A in the SPLAT stands for activity. What was the person doing at the time of the fall? What were they trying to achieve? And if it was my dad, his trip up the stairs yesterday, he was trying to walk up the garden steps to hang out the washing on the washing line without actually taking his walking stick with us and using a basket that was very much overloaded, rather than sort of like asking for help or maybe taking a smaller load. But he got up, which was good. Quite pleased that he was managing to get up and didn't hurt himself. The T's, the time of fall, and that could also be the, sort of like the time that they last ate, the time that they last went to the toilet, the time that they were last checked on the intentional rounding, and also the time of any previous medications. And one of them to think about also is any sort of like sedatives or lorazepam. If somebody's very anxious, were they then given something to help settle them, which actually then has made them less coordinated and more likely to fall, and looking at what support may be needed if they need sedatives in future. And the final T is what trauma sustained. If I've got anybody who's got facial injuries or broken glasses, then I'm very often thinking that that person may have collapsed or had a syncope attack or fainted, or just that all the world's going out and they haven't actually had the righting mechanisms to put their hands out to save themselves. So that's one of the things that we also have a look at. So going back to the assessment, so you've done your history, talked about the current fall of what happened at that time, and then thinking about eyesight, hearing, footwear, previous medical conditions, what medications they're on, what their continence is, what their hydration is, what their diet is, environmental risk factors. There's probably a few other in those, but they tend to be the main topics that we look at. Sorry, that was a lot of information that I've dumped in you.
Thank you, Adie. I did see a hand up from, I think it was DJ. I don't know whether you wanted to come in or are you okay?
Yeah, I think I was about to chip in something about the assessment in care home. You may mention of something in your presentation whereby you talk about residents having a bad day and thinking about how to be in bed. So in my little experience, I think if you look at the residents in care home, like 70 or 80% of them will actually like to be in bed. We actually like to remain in bed if you allow it. So I'm just looking at where we'll be able to look into the assessment in that area, because if you say you want to let them be without prompting, like they want to be in bed, most of them might be in bed like that, and before you know it, might be declining or preventing them to walk. In most cases, we need to assist them to pass through them and prompt them so that they keep exercising the bones and surface. So I'm just looking at
Yeah,
that
I think
assessment, how it comes in,
Yeah. So with that sort of like getting up where you've got somebody in a care home to stay in bed or not. So I know Lisa was very much on the section that was her section with under the Parkinson's and that having that morning rest, because I do find sometimes that somebody with Parkinson's, if you give them a cup of coffee in bed and their medication, an hour later they're probably ready to get up bed and their mobility is much better. But I know very often a lot of people who are living with dementia, their routine changes and they find that very often it's the night time that they're more likely to be up and about, and that isn't always the routine that the home is in. And very often I know that when I go and see patients in a care home, I'm very often looking at the routine that somebody's got and whether or not they're going to be somebody who's going to be willing to go down to the communal lounge, because then actually you've got staff more available, you can keep an eye on them and you can support them. Whereas if they're isolated in their bedrooms, you've then got to sort of like look at your intentional rounding checks and think, how often are you going back to see them? What support do they need? Do you need a falls alarm in place in order to be alerted when they're moving? How are you going to maintain their hydration? Is it a case that actually they get up and they have their breakfast, their water, their tablets, and then maybe go back to bed for an hour and then come back? It's an individual basis of what suits, and it's very much, it's not a one size fits all. It's what is our resident doing, what is their preference, what works for them, how do we make it managed? Some of the residents, when I go out and see them, we've looked at moving them closer to the nursing station or to a downstairs bedroom when one's available, because of the fact that they do want to stay in their bedroom. But we've also looked at having family come in the morning so that they're actually something to get up for, a purpose. And I've got one gentleman who I met a couple of weeks ago. He actually gets up and goes and helps with the laundry as part of his work routine, he says. So it's his laundry that he's doing, but himself doing the laundry is giving him a purpose. I think he doesn't particularly do a lot of the laundry, but he sat there chatting to the person who's putting it in for the washing, and then they have a cup of tea at that time. But also none of his stuff gets lost, which is quite good. So it's being creative.
Thank you, AD. DJ, did you have anything else to ask about that particular thing? No, you're all good. Thumbs up from DJ. Thank you. We've got two questions from Helen Lake. Helen, I don't know whether you want to come on and ask them, but there's one around. Oh, is Helen around? Do you want to come on and speak?
I am, yeah.
Hello, Helen.
Hello. I am actually a staff now, but I have a good friend who is 99, and he has recently been falling a lot in a care home. So I'm asking lots of questions in order to sort of try and think about how to support him within the care home. Up until sort of the past year, he's been very mobile, and I just was trying to think about the sort of proactive side. But he has also, I think I mentioned the last question was around him. He's aware that he's lost a lot of his strengths. He has had several falls and ended up with cellulitis and knocks on his elbows and things like that, which we're worried about. But also he's aware that his legs sort of are giving way. He's not as hasn't got the strength that he used to. I'm just wondering about, he probably has the wherewithal to work out how to fall a bit more safely if he's given some advice about that, and if maybe he had a bit more support. And I wondered if there's anything around that area that you might look at.
Okay, so keeping it generic as to what we look at when somebody's mobility is reducing, it's looking obviously at sort of like what the risks, what the causes are, what the distance they can walk, whether or not actually they need to have a walking aid, whether or not it's something that they'll be able to use, what level of supervision they then need in order to use that walking aid, whether or not they're able to call for help, to ask for help on moving, or whether or not they're going to be somebody who gets up and tries to walk them without the aid. But I know with a lot of the homes that I've been in, that I've gone into, one of the ways that they try to maintain people's strength is actually saying, like, okay, you're not able to walk the whole distance now down to the lounge, but what we'll do is we'll walk part way and we'll have somebody else follow behind with that wheelchair, so that when they get tired, they can then sit and rest and then come the rest of the way, rather than actually going, right, actually, no, we don't want you to fall. Let's go the whole way and in the wheelchair. So I know that's one way that a lot of the homes put in place to enable people to maintain that strength, because if we don't use our ability, then we do lose it. The fact that he's 99, it's kind of like looking at actually if he is falling, what is the likelihood of him actually breaking something? Again, Lisa mentioned about the risk factors, the facts, and the calcium checker and the calculator. Has he got a good calcium intake? I tend to also have a look as to whether or not what level of support somebody needs for toileting. And for some people, if they're in that stage where they're mobilising independently, they don't quite need somebody to supervise them all the time, but actually they are the ones that, you know, they are a risk at falls, but they don't need that supervision all the time. They're the ones that I think, is this somebody that maybe needs to have hip protectors? Don't use hip protectors routinely with everybody. I probably use them in about 1 in 1,000 people, but they have been proven for some people that if actually they're high risk of falls, they need support with toileting, then they will reduce the risk of a fracture because they take the impact out. Also, the fact that they're 99, one of the things is looking at the diet, and a lot of the care homes are really good at actually promoting additional protein and additional calcium in the diet. They very often fortify the diet so that they're getting sufficient calcium as well, and that's going to help with keeping the bone strong and also keeping that muscle strength. But there are exercises which they can do in seating. And that can be something that I've encouraged families that when they're coming in, can they do maybe the seated exercises, or can they, you know, a couple of ball games, something to help with that. And also with the staff, what I tend to do is I look at how they can incorporate some of the exercises into the washing and dressing so that it's part of their daily routine, as opposed to being something else that they're doing. A lot of the homes I now find, 10 years ago when I used to go in, it used to be sort of like 1 or 2 homes had an exercise session going on. Whereas now I would say most of the care homes we go in, you will see that they have group exercise sessions taking place at least 3 or 4 times a week, which will help people to keep their strength. I've been asked several times recently about how do you fall? How do you fall safely? Can you teach me how to fall? The people who fall, I find the best very often those people who've done martial arts in their younger life, because what they tend to do is they tend to relax into the fall. They tend to make the curl up. They tend to make themselves nice and small, and they relax. Whereas actually, when I fall over, I tend to go rigid, and which makes me more likely to hurt myself. So it's that relaxing into the fall. And also, we don't recommend that people catch people to prevent them from falling. Your natural reaction is actually, if somebody is falling, is to try and catch them, but actually we recommend that you don't try and catch them, because the risk of actually hurting yourself is higher, and actually you can do more damage to both of you by trying to catch somebody. So there are people who, you know, when their knees give way when they're walking, if there's a chair available, then it's just that slowly assisting down to the floor rather than then trying to hold them up. But it is a case of thinking, how far can this person walk? But Helen, if you want us to have a chat afterwards, then I'm sure Sarah can give you my email and we can have a chat.
Thank you, Aidy. Sorry, Helen, I muted you because there was some background noise.
Yeah, no, that's fine. Thank you very much. That's been really helpful. Thank you both. Well, I'd definitely like to follow up with you. Thank you.
Okay, I'll put you two in touch then. Thank you. Has anyone got any other questions at all or comments on what we've been talking about today? Gone very quiet. No. Has this been a helpful session for those of you who've joined? Yeah. Is there anything else you guys wanted to say, Lisa or Adi?
No, just thank you all
No.
for joining and thank you for listening.
Yeah, thank you,
Excellent.
everybody. That was my first time giving a presentation, so
You did very well.
just a bit nervous.
Very well. You can breathe now and relax.
Yeah, I
and
can
good
breathe.
luck with your
Yeah.
studying.
Thank you very much.
Lisa.
Yeah.
Well, if there's nothing else, then I will close the session. But thank you so much for joining us today. As I said, I'll send you an email out, which could have some information. Maybe Lisa will be willing to share her presentation. We'll do a recording for those that weren't able to be here. If you do have any other questions, I think Adi was going to send me some information on the sessions for care homes and also the staff sessions for training. And also there is another session that we're running, but all the details will be in our email that will come out by the end of this week. So unless there's anything else, I'm quite happy to say goodbye and thank you very much, and I hope you enjoy the rest of your day. Thank you to Adi and to Lisa as well. Thank you.
Thank you
you.
very much. Thank you.
Bye-bye.